after recognizing the area of interest, the clinician should determine whether the entity of interest is a variation of normal or an abnormality. If the area of interest is abnormal, the next step is to decide whether the radiographic characteristics represent a developmental abnormality or an acquired change. For example, did the tooth develop a short root, or did the root develop to be of normal length and then became shorter? Then comes the classification. If the abnormality is acquired, the next step is to select the most likely disease category for the acquired abnormality. The disease category can be established by observing the features and how they reflect a particular disease mechanism. The categories may include inflammation, cyst, benign neoplasm, malignant neoplasm, bone dysplasia, vascular abnormalities, metabolic diseases, or physical changes such as fracture or trauma. After a disease category or a differential interpretation of a disease is determined, the clinician must decide how to proceed. This decision may require further imaging or biopsy or observation in terms of follow-up or a definite treatment. Only going to be discussing few of the common ones today. How we can differentiate on the basis of radiographic features between the benign and the malignant lesions. So the following characteristics can help us to differentiate between both the categories. They can, the features which can be used to differentiate are margin characteristics, shape, internal architecture, and its effect on the surrounding structures. So what are the characteristics of benign neoplasms? Benign lesions growing in bone tend to be usually round to oval in shape, and they grow by displacing the adjacent structures and tissues. And as the benign tumor extends towards the periphery of the bone, the periosteum lays down new bone along the outer cortex, maintaining the integrity of the cortex. This is also called as the periosteal bone reaction or the periosteal laying of the new bone. Ameloblastomas are by far the most common odontogenic neoplasms. This neoplasm arises from odontogenic epithelium derived from the remnants of the dental papilla and the enamel organ. They grow very slowly and are usually asymptomatic in early stages, but as the lesion increases in size, they result in facial asymmetry. So this panoramic radiograph here shows a large unicystic ameloblastoma developing in the left posterior mandible, causing expansion of the mandibular body and ramus all the way up to the sigmoid notch. And as you can also see, it has caused the inferior displacement of the inferior alveolar nerve canal on the left side. These two radiographs here also shows the presence of and the radiographic appearance of ameloblastoma. The first one is a periapical film, and the second one is the occlusal image. And you can see the presence of short septa developing into ameloblastoma here. The second image on the lower right is the coronal MDCT image. The size of the ameloblastoma often dictates the aggressiveness of its management. The most common treatment is the enucleation with surgical resection. Malignant lesions have a very ill-defined margins. They do not have a defined shape, as in contrast to the benign lesions, and are mostly radiolucent. They also have an effect on surrounding structures and can lead to floating teeth, as they tend to resorb the roots and they cause the destruction of the surrounding structures, such as inferior alveolar nerve canals, sinuses, or cortical borders, and causes the bone destruction and the perforations.